So I want to talk about a recently released document that you and Paul Coombs at U of L put out, talking about where we're at in terms of COVID, especially testing and reporting and things along these lines. You guys in the report talk about how back in around May, at the beginning of the pandemic, we probably were not reporting to the point where we had 10 times more cases than we thought we did. And now, even in September, it's kind of one out of every two, I think you said. So what does this say about where we're at, who this virus is infecting, the mortality rate? If we're not getting it right, what does that say about the virus in general?
Well, I mean, one thing about this virus that you have to keep in mind is it's different than many other viruses we've ever had to deal with. And people are still struggling to understand the impact of that. It tends to, a lot of people that it infects don't ever have an infection or don't ever show any symptoms. Excuse me, misspoke. Don't show any symptoms. So as half of them show no symptoms. It does tend, the people who show symptoms tends to vary, they think, by age and other characteristics. And then how badly it affects people also varies. It has very heterogeneous impacts on people, which again is very unusual. Things like Ebola and tuberculosis haven't in the past. And so, for example, we know that you're much less likely to die of the virus if you're young, and much more likely if you're old. There have been studies that have shown, for people under the age of 30, the probability of death is close to zero, whereas people over 85, it's 36%. 36% death rate is enormous. It's huge. I mean, that's unlike many things we've ever seen. But for people under 30, that's quite, it's no more riskier than getting a flu. And so then you struggle with what's the policy? How do you prevent the most vulnerable from getting it? While still trying to let people who aren't likely to be affected continue to function. And how do you test in an environment like that? Again, with traditional things that have spread pandemics, people who get it get sick. So they go see a healthcare person and they get tested, and the test says, "Oh yeah, this is what you've got," and that's not what's happening here. And so that makes it extraordinarily challenging to figure out how to track it and how to keep track of it and how to assess how to develop policies to fight it and how to assess the effectiveness of those policies. And the numbers about, only 1 in 10 people were being infected, those numbers come from the CDC, the Center for Disease Control. They did some seroprevalence work where they were getting blood drawn in various areas that had been drawn for a variety of different reasons, and testing those and seeing whether the blood that had been drawn for people who were having other types of surgery or who had given blood, who, whatever they had done, for whatever reason they had blood drawn, they tested that. And back then, by early on in the pandemic, April, I think it was 10 to 1. By June, it was 4 to 1. In our report, we use estimates from model-based estimates of the number of people who have been infected, who take all of these things into account. And based on those model-based estimates, the numbers bouncing around 2 to 1 bouncing around about 2 to 1 towards the end of the data that we study in the report, and that's through the end of September. So what is it? I mean, the problem with, again, what we've done traditionally is we just test people who show symptoms. Well, that's not good enough here, because lots of people don't show symptoms, but those people who don't show symptoms can be still infecting other people. But we have persisted with this, our thinking that has been developed with previous infectious diseases, that we don't have to go out and find people to test them. The people who are sick come to us. Well, that doesn't happen here. So the data that we collect from these tests of people who voluntarily go and get tested is flawed, is biased. It's not a random, it's a very select sample of people who not only got it, but got it poorly enough, that feel poorly enough that they choose to get tested. And remember, getting tested is not a very pleasant event. I've been tested. I'm assuming you probably have too. It's not something you're probably going to run out to do just on a whim. So the data that we get is just fundamentally off. It's flawed. To be able to use the data appropriately, you have to collect it differently, or you have to recognize the biases that we have evidence for and adjust the data appropriately to reflect the fact that not a random sample of the population is showing up to be tested. People who are the sickest are the ones who likely are being tested. That means, when you're using flawed data to make decisions, you're making bad decisions. In light of the chamber's, constituency, if I went to a business leader of a Fortune 500 company and told them the data that you're making your production decisions on are biased. Here is evidence that they're biased. Here is how they're biased. That business leader would say, oh my God, my decisions I'm making with these data are bad because I'm using bad data. I need to invest in getting better data. And then I would say, here's how you do that. They would say, great, let's get the best data so that I can make the best decisions because my profit depends on it. If I'm not making the best decisions, I'm not making as much money as possible, and my shareholders are suffering, my owners are suffering. So I need to be making the best decisions possible so that I can make the most money possible. In this situation, it's even worse because when we're making bad decisions, we're designing policies that impose enormous costs on people who aren't particularly at risk, or we're not allocating resources in the appropriate manner possible. So we're not protecting the most vulnerable. So in some sense, we are making poor decisions on how to allocate resources. When you do this here, more people than necessary could be dying. And that's what frustrates me more than anything else. It's not that this is not a serious, it is very, very serious. This virus is very serious. We should be taking it seriously, and we should be trying to develop the best data we can to combat that. I'm sorry, I got on a soapbox a little bit there, but
no,
there you go.
To your point about making sure that we get the best data possible and going to a business and saying, you're doing it wrong, this is how you should do it. What is your suggestion on how do we change things to make sure we are getting the right data if we're currently doing it wrong?
This is the recommendation that almost every social science researcher that I know of has made since day one. We should be testing lots of people. We should be doing periodic random testing of the population, much like they're doing in Louisville through the Co-Immunity Project. Testing 1 week, 2 weeks later, test another random sample. These testing them repeatedly allows us to have much more accurate, better measures of how the virus is spreading over time. We're very concerned about whether more people are getting sick right now. And it's not simply that the number of tests that we're conducting, it's who we're testing. Again, one of the things that we know is that the virus affects people differently. Not surprisingly, if I tell you you have almost no chance of getting sick, you're going to behave differently than if I tell you, or if you get sick, you have very little chance of dying. You're going to behave very differently than if I tell you, if you get sick, you have a 36% chance of dying. Okay, that's great. We know that young people have a very small chance of dying, and they behave differently than the elderly in this. We can yell at them all we want about you shouldn't be doing this. But the fact of the matter is, given the probability that they're going to get sick, what they're doing, you're going to be hard pressed to change their behavior because they are at risk. You know what? Turns out people between 20 and 29 are 2 to 3 times as likely to be infected at any given point in time than someone over 65. Okay. So now all of a sudden I start, and we also know from a variety of different sources, in particular, some of the recent work, again, done by the Co-Immunity Project in Louisville, which is testing random samples of the population in Jefferson County. Minorities are more likely to be infected. Okay, so now I'm wandering around and I'm doing some testing, or testing only people who show up, and the people who are most at risk and likely to show up are the elderly. All of a sudden I start testing a lot of different people. Let's say I start testing young people because, oh, maybe they're going to college, and now every university on campus in the state is testing all of their students on a fairly regular basis. Again, those students, even absence of showing up on campus, are twice, 2 to 3 times as likely to be infected. If I simply, it's more likely that I'm testing them now than I was 2 months ago. My infection rate could go up simply because I'm testing a lot more younger people. I don't, and to understand that, you actually have to have data not only on the results of the test, but actually who was tested. The state has never released data on who they're tested, the characteristics of who they're tested, the race, the ethnicity, the age of who is getting tested. They just tell you the number, so you have no way of ascertaining this effect. And so the rates are going up now. They're testing much more right now, okay, but the positivity rate was going up for a while too. I don't know what the governor has stopped. The governor flips flops about whether he talks about the positivity rate or whether he doesn't mention it, depending on whether it's up or not. So I don't know what the positivity rate was a couple of days ago, but it was going up for a while. Well, that could simply reflect an increase in the number of people getting sick, or it could reflect simply that we're testing a lot more young people. I don't know that. I have no way of determining that from the data that the state releases. What I do know is if I was doing random testing, drawing random samples of the population, that wouldn't be a problem, because essentially what a random sample assures you is you are testing the same type of people time and time again. And so the best thing to be doing would be doing the periodic random sampling, so we would actually know whether the virus is spreading more quickly or not. We don't know that currently with any degree of accuracy. And it would, then again, it would help us adjust in between periods when we just have the daily reports, how we would adjust those daily reports to give us a much more accurate, much less biased estimate, and something much closer to the true estimate of the number of people who are getting affected on a daily basis. And then we would know whether we are setting records on a daily basis. Because right now, there were a lot of people getting infected in April and May. We just didn't know about it. So the question is, are we just discovering these people that have been infected all along now, or is it really an increase? We don't know that. And for me, that's very frustrating.
And that's exactly what my next question was going to be, is do you think we actually are higher than we've ever been in terms of cases? I think we're hearing that a lot. And yesterday on Wednesday, the positivity rate, it looks like, was 6.3%. We are seeing a lot of cases reported, less than a lot of other states still. But still, I think that people are still very confused, and children going back to school and things like that. There are a lot of factors that I think people are blaming this on too, which, to your point, it's hard to know where people are getting it and things like that. So where do you think we stand? Do you think that people have had it and are kind of immune now and are maybe getting it? Like, where do you think we stand?
Well, I will say, we are however you want to define herd immunity, we are a long way from there. I think if you look at the model-based estimates and the estimates based on the CDC data from the CDC, from the serology estimates from the serology surveillance that they've done, some about 6-7% of the population in the state of Kentucky has had it. As of the end of September, it was 220,000. Whereas if you look at the state's numbers, their numbers say 66,000. So their numbers say 0.7%, and the CDC numbers say 3 to 4%. Yeah. So the first thing we know the state numbers are wrong, and wrong by a lot. And we know that the numbers back in the spring were gross underestimate. We just don't know what the truth was back in the spring. We have better estimates than what the state was producing. So whether the fact that I don't know really what went on in the spring means I really don't know whether we're unusual right now. So there's no way of knowing from the data that the state is producing whether we're a lot higher now or whether we're just discovering a lot more of the people that were sick than we've ever done before. Because again, I mean, if you look at the number of tests that the state is doing, back in the beginning of September, they were testing about 5,000 on average. If you average over a 7-day period, and that's important to do, there was one day in September, all of a sudden there were 140-some thousand new tests that were reported in their daily report. That's another thing that happens, and I don't know what occurs because I don't have access to that, but my guess is in the end of September, they got a bunch of data dumped on them by universities and colleges who tested their students, and all of a sudden, boom, they showed up. And so now on average, it looks like about 20 to 30,000 tests a day. But I suspect a lot of those tests, again, are reflecting the fact that, I know UK is testing kids on a lot of kids on a daily basis. These are kids that would never have gotten tested before. And you know what? At any given point in time, a good, some larger percentage, healthy percentage of them are positive, and they're just showing up, but they'd be positive almost regardless of what was going on, where they were. And so they've always had high rates of infection because, again, they're the least vulnerable.
So, but to your point, and kind of what's being communicated at the state level and the national level in some ways is there's more positivity now than ever. And again, we don't know that. But to your point, the numbers are probably off by a lot in a way that shows that there's less than we actually have, So should people be concerned, talking about kids coming to school, not knowing they have it, they do have it. How do we, because like you said, this is still very serious, especially for older populations. I mean, 36% is a huge mortality rate. So continue to protect those people while still keeping things running.
And I think the first thing to do is start to figure out who has it, how it's changing over time, and also come up with better models of and through random testing and gathering information, how does the disease spread from the young to the old? I must admit, it's the 50%, 90% of the deaths in Kentucky have been for people 65 and older. 50%, still over 50% of the deaths have been in group homes, in nursing care facilities and things like that. So it's clear that they're the most vulnerable. You've got to explain to me how closing schools down protect those people. And maybe they do, but we have no evidence to suggest that it does. And actually the evidence that we do have that was produced back earlier that looked at policies concluded that closing schools down didn't have any effect. It would be nice if we were doing large enough random samples that we could understand infection rates by age. And then fatality rates by age. I mean, I think our infection numbers understate the number of people who are sick, who are infected at any point in time. I think it is actually much higher, but I think the other issue is, I think our information on who's dying from this is much more accurate. So if I've got an accurate count of the number of people who have died from it, but the count of the number of people who are actually sick at any point in time is too low, then the fatality rate looks a lot higher than it is. I mean, if you look at the case fatality rates, they are 3 to 4% on average. So 3 to 4% of the people who get it die from it. If you look at estimates of the infection fatality rate, both ones that I sort of really back of the envelope calculations that I did that Paul and I did in our paper, or actually meta-analysis that has been done by collecting data from a lot of places that had it before, the estimate of the population fatality rate, both mine and theirs, is 0.7%. 0.7% is, again, it's serious. The death rate from the flu is 0.1%. So 0.7% is a lot higher. But it is much lower than that fatality rate of 3 to 4% that you get by taking the number of people who died divided by the number of people who the state reports has had the disease. And so it is, and again, I think part of this allocation of resources is closing schools is extraordinarily expensive. The estimates that I've seen suggest that shutting schools down for a 6-month period, much like we are talking about doing in Fayette County and Jefferson County, will cost school-age students in the state somewhere between $8 to $12 billion in lost lifetime income, $1 billion. And unlike the claim by this Fayette County superintendent that they're going to make it up over time, they're not making up this loss in education. If they could make it up, then we should have been doing that in the past. So that really makes no sense. And it's also the case that the students that are going to suffer the biggest losses are low-income students, minority students whose parents don't have the time or the ability to help them with their schooling. They can't hire someone to come in and tutor these students. Their internet connection is not at the same quality. Despite the best efforts of the school district, they just don't have the same equipment. The youngest people in the state are paying the biggest cost of trying these preventive efforts while suffering the least, so getting the smallest benefit. That, in and of itself makes it very challenging to figure out why that this is an effective policy. Just the numbers are just hard to say that this is, given these large costs and the difficulty in establishing a relationship between locking schools down and keeping the elderly healthy. It's just hard to justify that policy just based on the numbers that I've seen. If you want to justify that policy, you need to be collecting better data. There have been a lot of studies I've seen that suggest that more targeted policies, targets at, locking nursing homes down, targeting more efforts at isolating and protecting the elderly, while having other folks, younger people continuing to work, would generate about the same outcomes at a much lower cost, or could generate much better outcomes at the same cost that we're paying now. So that's part of what makes me so frustrated about the poor data are, again, poor data lead to poor policy outcomes. Better data could have produced better policy outcomes. And by better, I mean achieve the same outcomes at a significantly lower cost. And so that's again, one of the things that I find particularly frustrating about the lack of effort at doing what any business leader in the state would do, is when you point out your data are bad, so you're making bad decisions, they were said, then I'm going to invest in better data so I can make better decisions.
So where do we go from here? Obviously, we've talked about how maybe we should look at what the Co-Immunity Project is doing random sample testing. In the report, you guys talk about testing wastewater,
yep.
Which is something that's been talked about. But in general, where do we go from here? What do you want people to take away from this report in terms of the fact that we have more cases than we think we do?
I think where we go from here is we need to push policymakers and healthcare professionals to better understand the issues with the data that they have, so that they can adopt better data collection methodologies. We know from the Co-Immunity Project in Jefferson County, you can do random sampling and testing random samples of the population successfully. We've seen it up in Indiana. Indiana was particularly successful because the governor was behind them. The state got behind them. The state pushed people to do it. The state advertised it. Instead of our governor standing up and telling people we're not doing enough, he should be saying, we're going to set up this testing program so we can better track the spread of this virus, so we have a better handle on how to fight it, and how it's spreading, and urging everybody when you get your card asking you to go get tested, to go get tested. That would produce much better outcomes for a reasonable cost. It's not cheap, it's not free, but we're spending a lot of money testing people, and it's producing data that's not particularly useful to combat this disease. So why don't we spend our resources more effectively to produce better information that allow us to design more effective policies to prevent more deaths?
All right, Dr. Troske, I really appreciate you taking the time to talk about this today, and hopefully we will be getting better numbers soon and seeing better outcomes, but I really appreciate you taking the time to talk to me today.
Thank you, Jacqueline. I appreciate you guys making the efforts to chat with me about it. Yes, I truly, you know, I must admit, for me, I voted for our current governor. I want to make that clear. I voted for our current governor. I believed he was the best choice at the time, and given the choice again, I would probably vote for him again. But I find it very frustrating that in this manner, I'm at a loss to explain why something that would seem so obvious to a large percentage of the population just doesn't seem to be. And I should be clear as well. We're not alone in this. I mean, no state. I would say very few states are doing what I think we should be doing, and there is no leadership coming from the federal government on this issue, and that's probably. You know, if I could change one thing, I would like to see better leadership coming from the federal government. I actually think that the current president, had he taken this seriously and implemented some of the testing measures that I'm suggesting, would have much more powerful arguments about how to fight this than just his tweeting that he does. And so, and then I think he would have been more successful in the most recent election. Not that we know whether he won or lost. We studied Kentucky because we're in Kentucky. This problem is prevalent throughout the country, and I do think it all starts at the federal level. But the fact that everybody else is doing something wrong doesn't, my mother used to say, just because your friends were jumping off a cliff, would you do it as well? I think that applies here, and we should be smart enough to overcome the limitations or the lack of leadership at the federal level.